Welcome to Health and Wellbeing Live. Today we're talking to Tim Guyler. So this is a podcast from the Place-Based Partnership in Nottingham City, sharing knowledge and experience within the city, aiming to keep people informed about issues, people, services that support the health and wellbeing of people in Nottingham City. So today we're talking to Tim Guyler. Tim is the Director of Strategy and Integration at Nottingham University Hospitals and is the Executive Lead at Place-Based Partnership, and we're looking to see what's in Tim's in tray for 2025 and beyond. I'm Dr. Andy Foster. I'm a GP. I am a director at NCGPA, which is a local GP federation, and I'm the Deputy Clinical Director at Place-Based Partnership as well. Welcome, Tim. Do you want to introduce yourself?
Hi, Andy. Yes, thanks very much. So, hey, everyone. My name is Tim Guyler. As Andy says, I'm Director of Strategy and Integration at Nottingham University Hospitals. That means I lead on strategy, planning, partnerships and integration broadly. And more recently also picked up the role as Executive Lead and Convener for Nottingham City Place-Based Partnership, which I'm delighted to do.
Great. So it's a really good opportunity at the beginning of a new year. So we're just moving into 2025 as we're recording this. And I'm really interested to know what you see as the main challenges or opportunities or issues, really in each of your main roles, Tim. So you might want to start with NUH, you might want to start with Place-Based Partnership. But what do you see as the big things coming up?
Thanks, Andy. So perhaps let's start with NUH, because in effect that's a part of the partnership, and then we can talk about the partnership more broadly afterwards. So from an NUH side of things, the way that we frame our focus at NUH is through People First, which is our organisational strategy. And People First has 5 main strategic priorities, which are around quality patient care, around patient flow, around retention improvement of staff, around culture and leadership throughout the organisation, and around financial sustainability. So there are 5 broad areas through which we clarify what our objectives and our aims are. And they're underpinned by a number of strategies to achieve those. We have 3 primary clinical strategies, which are around elective care, so planned care, around non-elective care, so responding to urgent care needs, and around specialised services, recognising we have a very significant specialised services role as an organisation, as well as the local DGH services that we provide for our local population. And then they're underpinned by a suite of other, what we call enabling strategies, ranging from digital to estates to partnerships, integration, etc. So that's the way as an organisation we frame our objectives and what we stand for in order to achieve the outcomes for the populations that we serve.
Good. So that's a really good overview, Tim. I'm just wondering, within that, what is there any particular area that you're particularly excited about for 2025?
I mean, it's interesting, isn't it, when you ask the question in terms of issues, challenges and opportunities. I think they're kind of the same ends of the same continuum, aren't they? Different ends of the same continuum, because many things that are a challenge are equal an opportunity, or many things that are an opportunity will be challenges with achieving. So, I think what we've seen over the past couple of years, there have been some really challenging times at both NUH as an organisation, and we know locally within our local health and care system. But within that, we've seen some really substantial progress and improvements across a number of areas. So whether it's about improving the quality outcomes and the care outcomes in a number of areas, whether it's around particular specialties, whether it's about cancer outcomes, etc., there's been some really good progress. Whether it's about some of the new developments that are coming through around, for example, the new neonatal unit at Queen's, or the Community Diagnostic Centre, or the National Rehabilitation Centre that NUH are proud to be taking the lead for. So there's some real good development in terms of like strategic direction, strategic builds, which will serve the population, or whether it's the access targets, which we know have been a real challenge since the back of COVID. And we've seen really, really good improvements in a number of areas across elective surgery, in terms of reducing the amount of patients waiting over 65 weeks for care, and that reducing further, or whether it's about the cancer standards, or whether it's about the amount of people being seen within 4 hours ED, or the turnaround times for ambulances at the emergency department. So notwithstanding in many of those areas, there's more to do. There's been really good progression in a number of those areas. And, one of the things that really strikes me, I'm I'm locally born and bred. I was born in City Hospital. My father was a GP in Nottingham for 25 years, and as well as being privileged and doing the role I do, I really enjoy it. There's a very personal element of that. I think of my own experiences, and I think about the experiences of my loved ones, my family. My two boys were born at City, and our family will always be provided with healthcare in our local population. And when I walk down one of the corridors at City, between the North Corridor and the South Corridor, I can remember even to this day waking up on that corridor, coming round, as I remember it, from an appendix operation I had when I was 9. And so behind, I guess, all of those things I've described as opportunities, there's a patient experience, there's a family experience. And that's the thing that makes me most excited and passionate. Notwithstanding there are challenges ahead for all of us, all of the improvements that we can make at the end of the day improve someone's lives. They improve the lives of the people around them as well. And that's, I think, what we're also privileged to have the opportunity to do.
Yeah, absolutely. You just tell us how important these services are to people of Nottingham. I've been in the hospital twice over the last year and had a GA, so I can appreciate that story of waking up on one of the wards and actually, how kind the staff were, and actually had a very positive experience. So I appreciate it can be a mixed bag for people. Just sort of looking forward from a sort of patient perspective, or from the perspective of the community partners out there. One of those is general practice, but there are other community partners out there. If in 1 or 2 years' time some of these programs have been successful, what might be different about our experience of kind of interacting with NUH?
Yeah, thanks, Andy. So if we look at each of those in turn, from a patient side of things, I think we look at improving access, we look at improving experience, and we look at improving outcomes. So we would hope that citizens who need to use services and come to NUH as part of that pathway should, in the main, receive their care quicker than they currently do. They should, in a greater amount of times, receive a positive experience of the kind that you described. And many of our patients' feedback, they have received a positive experience, but it's not universal. It's not across all specialists all the time. We want to improve on that. And that's never a binary state of it all be right or all be wrong. It's a journey of improvement. People should more often than not receive good care and have a good experience, and the outcomes should be better in terms of the way the patients report it, and also the longevity and the healthiness of life as a result of that. And that's the challenge that we want to have across all of our specialties. And to do that, I suppose there's two parts when it comes back to your question of what will partners feel. There's many parts of that as a hospital we can improve ourselves. But there's many parts of that actually which we can only do by working differently in conjunction with partners. And so there's already a lot of work that's going on, whether we want to think about the primary secondary care interface work that's been going on with GP colleagues and hospital colleagues to understand what makes it difficult currently in the way the hospital works for primary care colleagues to care for their patients, be it in terms of getting the information they need, referring them, making it easy to do so. Where patients don't have the information they need, so they have to contact their GP to ask a question that actually the GP can't answer because we need to be answering. And we're trying to improve all that so that people have the information they need and don't unnecessarily bother their GP who are already busy with things that as a hospital we should be answering and making sure people know. And also making sure that in terms of if as a hospital we're undertaking tests, that we're following up the tests. So there are a number of things that I think that the colleagues are already starting to find are better, but we have more to do on those. And then we've got areas such as the emergency care work that's going on, where there's a different now model of care for non-urgent emergency care with an ED, where it's being much more focused and provided by primary care partners such as NEMS rather than being a hospital ED-led service. So we're working with partners to provide our services in different ways.
Yeah, really good examples there, Tim. And as a GP, I have noticed some of those changes. Actually, there's now a way that we can share care back better to the hospital through something called the 5 asks letters, which myself and colleagues are using when we feel that we may have been asked to do something inappropriately by a secondary care colleague. And also I notice I think as a result of some audit work in the emergency department, we're no longer asked to do an x-ray 6 weeks after somebody's been to the emergency department as we used to be asked. That disappears, but people often don't notice what isn't there anymore, so it's useful to discuss those things. Tim, I wonder if we might move to the place-based partnership, because that's a newish role for you. So coming to that role as a fresh person with fresh eyes, having had a bit of a history with that group already, what do you see as the big things coming up for place-based partnership in 2025 and beyond?
Thanks, Andy. So, I think the first thing to recognise is, it's this challenge on opportunity in equal measure. Is I don't think there's an organisation which are represented within the place-based partnership who don't have some significant challenges of their own, be it financial, be it activity, be it work pressures, etc. So there could be a real risk that when we're all under such significant pressure, things become a bit insular and you kind of focus on your own things instead. I think that's a real risk. The flip side is there's a real opportunity here, because we've already seen examples through the work the partners have done together of how, if we understand the way we currently work and we understand the way we could work, there are some really significant opportunities that can improve the experience of our population, the outcomes of our population, and the experience of our staff who are working within our organisations, who often will know very well where things just aren't working as well as possible. I think it's our role as a place-based partnership, as the leaders within the place-based partnership, as a convener of the place-based partnership, to bring those colleagues together and to have the bravery to say, in a very, very busy day, we're going to create time for people to come together, because we think that time will be invested in a good way, through which we'll find different ways of working, and we can change the way that we work going forwards, doing things in a more seamless way together. And there have been some great examples, so from work that's been done across citizens who have severe multiple disadvantage, for example, and the work of Framework as a homeless charity, the community and voluntary sector, primary care, community care, understanding how we care for that really challenged group of individuals who have significant disadvantage in life, and recognising the way we all individually did it previously. Everyone with best intent was trying to care for those individuals, but it was fragmented. It probably didn't meet their needs in a way that was accessible for them. And then by understanding it and working it differently, those needs are being met in a much better way. And the described outcomes that have changed in terms of the healthiness and the well-being and the connectedness of those colleagues and their needs being met has really been advanced. And I think that's just one example, I think, of where we have to work together, because citizens don't have individual needs put into individual boxes that singular organisations can meet very often. It's a team game of all of us.
You spoke there about sort of a little bit about the difficult times that we're in terms of levels of funding, staff morale, other challenges that are felt across all of the partners, both NUH, community providers, in general practice currently, as we talk at the beginning of 2025, engaging in collective action and often trying to limit the amounts of non-contractual work that they do as one example within that partnership. Do you have any tips or approaches to be taken to try and ensure collaboration can continue and expand in this difficult environment?
Yeah, I think the first point is to be really respectful of the situation that colleagues find themselves in. And in the past we've been through an era of strikes across a number of areas, and obviously collective action is akin to that across primary care. And first of all, being really respectful of why that situation has arisen, and in a number of instances, people generally wouldn't want to do that, but feel no other way of expressing the concerns that they've got given the situations they work in. So, I think the first point is notwithstanding some of the risks and implications that may create, is being entirely respectful about why we find ourselves in that situation. I think what's really important as partners is that we don't allow that to break the relationships between ourselves. So what I've always found of any of the people that I've worked with is the common underpinning cause is people have come into this because they really care about the job they want to do, and they really care about the people they want to do. It's just that the challenges that they're facing, the situations that they find themselves in, are really significant. So my view of this is, we have to recognise the context that we work within. There's no point making an excuse for it, and there's no point pointing fingers or making any blame within it. That is the reality of the context. And within that, we can continue to have discussions and do pieces of work which will make things better. They'll make things better for each other. They'll make things better for our patients. And some of my biggest learning from when we started the primary secondary care interface work between NUH and our primary care colleagues, which it started on the back of an ask from our city GPs through the exec PBP group, which is, look, we're really struggling on the back of COVID. Can people help? Is there anything big colleagues can do to help? And whilst on the NUH side, things were under significant pressure as well. When I spoke to some of our senior clinical colleagues around that ask, their absolute first view was, well, cool, it's really busy for us, but of course we should go and have a conversation. Let's go and have a conversation, see if we can do something different. And the risk was that we went into that discussion with a viewpoint that it's difficult for me because somebody else is deliberately making that the case. As opposed to just recognizing it's really busy for us, it's really busy for you, we respect that, and then say, okay, well, what can we control? And I think we quite quickly got to a case where we asked a very different question, actually, a less defensive, a more open, a more inquisitive question, which is there anything I'm doing which is causing you a problem? And actually what we found out of that was a whole suite of stuff that we didn't know, that wasn't intended, but clearly wasn't the best way of doing things. But without that discussion, we'd never know about it. And that's what spawned many of the 90 projects that have come out of the primary secondary care work. Some of the things you've described about the finances, it spun out very practical things that we simply wouldn't have known. I think we've got to keep those conversations going that say, help me understand what it's like being on the receiving end of me, but do it in a mindset that if it's a problem, it's not deliberate. I'm not trying to cause you a problem. It will with best intent, and we need to retain that collegiate, positive, respectful dialogue through which we'll find opportunities to make things better.
Yeah, absolutely. I mean, just those basics of listening to each other, finding where the shared values are, the shared pain points. Yeah, really, really important. Tim, I was going to ask a little bit more about you, really. So, because a lot of people like to listen to podcasts like this and sort of think, I wonder what that person's journey is getting to where they are. How might I get into doing similar work, in the future? So I was just wondering briefly, what's been your journey to your roles in a way that other people might learn something from or be able to follow?
So my route into the health service was after university, I applied for and got on the graduate management training scheme for the NHS. And that gave me a really good entry and exposure to it. From that, I've undertaken a number of different roles, primarily within the acute sector, in operational roles and then in improvement roles. And it was from that I got a much deeper interest in systems improvement, system leadership, improvement science. So I did a master's in that. And then very much through both reading more broadly and in effect opportunities that came up because of what the national policy was around system working with, initially with the sustainability and transformation plans, then subsequently integrated care systems. There became the opportunity, I think, to work in a more cross-boundary sense between acute sector, primary sector. And there's been a number of publications which have really stimulated me in my thinking and helped me, explore why I'm so fervent in my belief there is a better way of doing things by working together. And there's a publication called No Hospital is an Island, which really acutes to say, look, you're part of a system, basically, which is a very good document. If I was to choose one that I encourage colleagues to read, it's just a 5-minute read with a cuppa. There was a really good article by the King's Fund about a health system in New York called Montefiore, which talked about the journey that an acute organisation had gone on, really moving from being very much an acute hospital looking at episodes of care to population health and system management in conjunction with partners. And from reading that, and both it took me a journey of what it might look like, but the way it was framed talked about the life expectancy of citizens as the person went down the tube journey across Manhattan. And it made me think, every day when I drive into work across Nottingham, the city that I've spent the vast majority of my life in, I'm kind of an autopilot, but it made me one day think and go, every single door I drive past, what really is the life and experience of those people within there? What contribution can I make? Am I aware of across the journey I've gone today, there's a 15-year life expectancy difference in the journey that I've gone? And that made me think so differently as a leader as to what am I about and what is my passion here? And then you realise that there's a much bigger goal and opportunity, and through partnership working, there's so much we can do to hopefully enhance the outcomes for our population that we serve. So that would be my 5-minute cuppa read, the Fiore document.
So I'm sure we can link to that down below, those 1 or 2 documents that you discussed there. Sounds really, really impactful. So we'll start to draw this to a close. Tim, thank you very much for spending time talking to me today and to those people listening. We ask everyone who comes on the podcast, does an episode, what next? So after people have listened, if they've got this far, what would you ask them to do next immediately after listening to this podcast?
Yeah, thanks, Andy. So other than perhaps the 5-minute cup of read, which I really encourage, I think if I reflect back, the most important thing that's probably happened in the past year or two from the integration work that I've been involved in and the place-based partnership work was in that primary secondary care interface, where under such significant pressure, we got together, we had a discussion, and we just said, help me understand what it's like being on the receiving end of me, and from that help me understand what I might be able to change. And I think if we can all be inquisitive, non-defensive in those questions, respectful of each other, we will find things that we can influence, that we can change, and we can really, it wouldn't be no single step, but we can continue this journey of improvement against a backdrop of significant challenge. But every step we make that makes it better than it would have been otherwise is well worth doing. But that has to start with us all choosing something to do, not waiting for other people, because it's those individual conversations that will stimulate those opportunities. Thanks,
Tim. And thank you very much for your time today. And thanks to everybody for listening. Thank you very much. And take care.
Take care. Bye-bye.